So I would like to have an overview of what has been of interest over the last 2 years. It will be mainly the last year. And I have to apologize because there is such a pile of interesting publications that it's always very difficult to pick some out. So I do apologize that I followed a little bit also my own interest, and so I do hope I will not disappoint too many people because their work is, for example, not mentioned. A first group of publications is directed to what is now becoming more and more a standard, and that's goal-directed perfusion. But luckily, because the problem is that goal-directed perfusion is now too much related to an absolute value of DO2. And that was never the intention. And luckily, we see now new research, like this research from the group from Magruder in the US, who is trying to correlate that also to other kinds of major morbidity, and in this case, specifically, the Society of Thoracic Surgeons outcome region. And as you will see, there is a good correlation with that outcome score. So meaning that, once again, the basic that we should take care of sufficient oxygen and targets during our perfusion. But keeping in mind that it's more than one organ, we would like to support all organs and have an optimal situation for all the patients. For a long time, we were puzzled. What should be done for goal-directed perfusion in pediatrics? And luckily, we had a few years ago this beautiful work from Mirella Beaujean, who was actually showing that in pediatric cases of normothermia, you probably would need something like 340 milliliters per minute per square meter. She is the only one till now who ever tried to correlate that to temperature, because we all know that in pediatric surgery, we do have quite a lot of different temperatures, and what should then be the ideal value. Anyway, the nice point is that in 21 and in 22, we had 2 new papers. This is the first, who is actually confirming those data. It's a little bit higher. As you can see here, it's 350 instead of 340 milliliters. But anyway, it's confirming the original data from Beaujean that this might be the trigger value. And as you can see, especially this value below this area could be a disadvantage for those children. However, never forget that this is always related to time. And that means, and this is another one which is doing exactly the same, they are looking again in the pediatric population on what should be a critical level. It's done in a little bit more sophisticated way. But again, if you look to the results, they come to exactly the same. And once again, you see no difference in venous saturation, for example, but it's quite obvious that the time you have been below that critical value is very important. And I would like to stress on that, goal-directed perfusion was never one value. It should be the incorporation of many values, and time is for sure one of these. And this is again confirmed by this very nice publication. And then again, it's more than just one value, and there is now more and more evidence that we should now target pressure. And pressure, again, is also not an absolute value. There are very few studies showing us that if you stay between 40, 50, or 60, 70, or 80, 90, that there would be a major benefit. However, and this is one of the studies which is confirming that, we should look what is the autologous regulation zone for a given patient and adapt the target of our perfusion towards that. This is very nicely done, and as you can see here, they were able, not only by the very difficult way of having Dopplers on the brain to establish this value, but you can also do it by near-infrared spectroscopy, which we have in a lot of operating theaters available anyway. So again, this is showing that there is a way in being more individual, more target-specific. And these studies are very helpful in order to establish this goal. But of course, oxygenation is not only the delivery. We start to have now very interesting methods which are looking to the mitochondrial oxygenation inside cells. This is a very preliminary study, but I think this is something to follow up in future. And then we have absorbance. We have more and more patients who have been on all kinds of drugs which are inhibiting our anticoagulation. So we need to have solutions for that, because not for everything there is a rapid antidote present. Now we do know that, apparent to the most recent information, some of the devices are able to remove quite a lot of this product within 1 hour. However, we have to be careful because there are still some questions. First of all, you see it's not as effective for every product. It seems to be 60 minutes, but what if you have a shorter procedure? What if you have a longer procedure? What is the impact of the flow over the device? There are still a lot of questions, but anyway, this kind of work will help us to understand what is the best approach to do. And then a little bit more in debate is, should we use that in more critical patients? I think it's interesting. This is a review, and I would really suggest that you read it. It's a very interesting review. But one of the flaws of this review is that they bring everything together. And that means if you have endocarditis, and the endocarditis has a normal anti-inflammatory response, you can wonder if there would be a benefit versus an endocarditis with a non-reactive anti-inflammatory reaction. And there is also evidence on that. So it's very nice because it gives you a very good overview, but be careful, there is still a lot of gray zone. And then there was also a disappointment when going through literature. When you look to this paper, which is a very nice survey, we see that although we manufacture a lot of protocols, a lot of guidelines, that it seems to be difficult for people to follow these guidelines in clinical practice. Because as you can see out of this survey, only 33% was using the arterial blood temperature as a reference. That's a little bit amazing because there is a pile of evidence saying that this is the best temperature, reflecting the real temperature in the patient. And even more stunning is the fact that no one apparently knew that going above 37 degrees might harm patients. So this means that we all have a lot of work in our own departments to convince young people to read more and to see, you know, this is the evidence. Let's try to bring this also in our practice. And the brain, of course, is important. You see here the impact of the cerebral oxygenation and the autoregulation during rewarming, because that's another fact. We do not do a lot of deep coolings anymore. But nevertheless, we all know that there are changes during rewarming. And what should be the best strategy? I can tell you this is a very nice article which is looking to some of the aspects we should take into consideration. And then we have some very nice reviews, which is also looking again at neurological complications. Two are of the group from Gudrun Kunst, who is present in the room, which is looking at the neurological complications in general, but very interesting also, how can we monitor? What are now the best possible techniques to improve that? Because we do know that as we improve perfusion practice, the brain and outcome of the brain will become more and more important, because even minor changes will be more easily picked up. And this is also related to many factors. For example, the oxygen delivery seems to be involved, but also even if you have sufficient oxygen delivery, the amount of hematocrit seems to have an impact. So we have to be careful to bring all this together, and that will be a huge task for the future. And then we have, and this seems to be an issue, I'm afraid there is something missing, but okay, I will bring it together for you. Can't show it, the other one. This is a very interesting paper, though. It's a paper which is looking to the organ harvesting. And we all know we have now something like normothermic regional perfusion. We do that by ECMO, but there are lots of questions. What pressure? What oxygenation? How should we do that? This is a very nice paper, and those who are interested, I do apologize, I don't know why it's not showing the article itself, but there is now a new device which is doing many actions at the same time. Though what is interesting, and that you can see, the upper part is done by ECMO. The lower part is done by this new technique. And you can see that you have a massive improvement of organ perfusion after the arrest, once this system is started up. So that means not that we should go for that system, that's something else. But it really shows us that we should make changes towards the way how we are going to do harvesting of organs in DBD donors. And then related to that, if we are going to work in this type of science, we need to know what is the science of hypoxia. And how do we treat that? How do we do the transition from hypoxic to normoxic situations? And I must say this is a very nice review article. I can really advocate it to anyone who wants to dig in a little bit deeper. It's very well referenced in what you can use and what you should do. And then finally, anticoagulation. It's still there. And we know even better than before that we should work on the ECMO issues more thoroughly, because with COVID, we do know there were a lot of issues. And this is the editorial of this article, which is actually advocating to use more specifically also combinations of drugs, which are not only working on the coagulation, but also on platelets. And to be quite honest, that will be the future. The only thing is, how are we going to incorporate that and control it? And this is a very interesting study, which is trying to do a first attempt in order to reach that. Many others, like this review, is actually looking on how the problems are situated, what we can do. That's the reason why I'm showing it, because we still need to have more background information. And then, if you talk about ECMO, and especially eCPR, how should we do the venting? I do not know one center where this is not a debate once you get in the situation that you need venting. Should we do it by placing a vent surgically? Should we do it by an impeller? Should we do it by using an intra-aortic balloon pump? Still, a lot of things are unclear. And this is a very nice paper giving an overview of what are the existing knowledge in that area. And then finally, it's the last one. We should also think, if we use more drugs, if we want to have better anticoagulation, it's extremely important that we try to see what is the exact concentration in the blood. And in order to do that, we have to have a good estimate of blood volume. This is an interesting article which was published in Perfusion, as you can see, where they're actually trying to improve the formulas and to see which formula is best in order to make these estimates. And finally, I'm very glad to announce you that the ESCTS, in combination with EBCP, is now, actually from January 23, changing the scope of what was called before the interactive into the interdisciplinary cardiovascular and thoracic surgery. And you will see some more announcement during the ESCTS convention, but I think this is the ideal platform for the future, because we will have to work together, surgeons, cardiologists, perfusionists, and we need to share that on a common platform. And that's the scope of this new journal. So I really do hope to see many of you as authors in this new journal. Thank you so much for your attention.